So I think you're all very familiar with this, the background facts about hepatitis C, and that we know about 200 million are chronically infected, which is about 2 to 3% of the world's population. And worldwide, transmission is still strongly associated with IVDU, and previously with transfusions, blood products, and iatrogenic. And the big problem currently is people who do have hepatitis C being unaware of the diagnosis. And certainly in the US and Europe, it's probably over half of cases are actually unaware that they have the infection. And certainly worldwide, 80-90% of people who have hepatitis C, chronic hepatitis C, are unaware of this. And we know that it causes progressive liver disease. We know 30% will develop cirrhosis and 5% HCC. And the mortality from HCV-related liver disease is going to triple over the next 2 decades, and it's currently the leading non-AIDS cause of death in the HIV population. We've no current vaccine, but you can eradicate it with treatment. So I think that's the good news. So again, that's just a little bit of background for you, which I'm sure you're all familiar. So whether you're likely to be co-infected with Hep C depends on how really you got your HIV. So if you're an IVDU, 80 to 90% in some studies are co-infected with chronic hepatitis C. And individuals with haemophilia, particularly those exposed to the non-synthetically manufactured blood products, have very high levels. And as we'll talk about later, acute Hep C in MSM. So this is quite old data, but it's not changed that much, in that you can see that the things that are driving the HIV epidemic in Europe differ as to the region. And so in Central and Eastern Europe, it's still predominantly driven by injecting drug use. Northern European, it's heterosexual, predominantly due to migration and an MSM. And again, as we said before, depending on your route of transmission, that's when you're going to have your likelihood of Hep C co-infection. And this is showed in the Eurocida data, with higher prevalences in the east and the south compared to the north. So I'm not going to talk terribly much about this, but I think you can't give a talk with Hep C without mentioning it, and that's acute Hep C and MSM. And it's been documented quite clearly in Western Europe, North America, and Australia, this rise in acute sexually acquired Hep C. And these are 2 graphs which show that the red are the earlier cities which documented the epidemic, and the blue are later, and it's been documented later in the States. There is a European network being identified and associated with high-risk sexual behaviours, concurrent STIs, and non-injecting drug use. But the good thing is the good responses to treatment in the acute phase that's been documented in many studies now. And I quite like the molecular epidemiology. I think this is quite interesting. And this was data presented at CROI in 2011. So what you can see is the phylogenetic study showing the European clusters, the Australian clusters, and the US clusters. And there's actually very little overlap, apart from a couple of Australians who made it to San Francisco. And generally what that shows, I think that's quite interesting, is that the epidemics have evolved simultaneously but independently. And they're associated with the same risk factors, MSM, late 30s, early 40s. Apart from Australia, non-injecting drug use, high incidence of sexually transmitted infection. So you've got these evolving epidemics which are independent but linked. And the thing that's interesting, particularly in Australia, where there is more injecting drug use, is that they're linked by the sexual orientation rather than the risk behaviour. So even if you're injecting drug use, or if you're a gay man, you're within that cluster. So I'm just going to give you, this is for us anyway in London, your fairly typical patient that you'll see in clinic. So he's a gay man, moved from Sydney to London in 2008 and was diagnosed HIV positive in February 2009. Immune against Hep A and B, which is good, you don't have to vaccinate him, and he was anti-HCV negative at that point. Reasonable CD4 count, viral load was fine. He went off and he was lost to follow-up for 2 years and then returned to clinic. So in the interim, he'd had a history of recurrent STIs. He had syphilis, gonorrhea, and LGV. He'd some intermittent IVDU when he went back to Sydney, and he was noted to have abnormal transaminases. And at this time, he'd seroconverted genotype 1A and an HCV RNA of about 600,000. And the difficulty with him is you've no idea when he seroconverted. If he was in the acute phase, fantastic, you can talk about treatment and the rapid responses, but we'd no stored sera. So it's likely, based on his STI history, that he's actually been infected for over 6 months. CD4 count was still not bad at over 500. Did his IL-28B, FibroScan was higher than we'd like, but he had normal ultrasound and synthetic function. So you're sitting in clinic with John, and this is really how your conversation goes, isn't it? These are the things he's likely to want to know. He wants to know how long he's been infected. Is he going to clear Hep C without treatment? How serious is it? Should he start on ART now? Should he not? Is there anything else he can do to protect his liver? He wants to know if we can cure his Hep C, and if we can cure it, what treatments are available now, and what treatments can you expect to have access to in the next 5 years? Are they good treatments? What are the side effects? And does he need treatment now, or can we possibly wait? Is treatment going to work in him, and does the fact that he's an intermittent IVDU exclude him from treatment? So I think these are generally the areas that we tend to cover in a clinical consultation, and I think they're the areas we'll just look at now. So is he likely to clear infection without treatment? In the acute phase, there have been a number of studies, particularly Emma Thompson in London, who've looked at spontaneous clearance of Hep C in HIV-infected MSM. And she looked at 112 MSM who'd acute Hep C, and what she found was that 15% of them were actually HCV RNA negative by week 12. And clearance was strongly associated with a very rapid, very acute drop in viral load, having an elevated bilirubin, an elevated ALT, and a high baseline CD4 count. So far, so good. But what she also noted, and which was confirmed in European data, is that you have individuals, these are the patterns of viremia, so the red ones are those that will spontaneously clear. And the black and the blue are those that are heading towards chronicity. But what you can see is you either develop a plateau of viremia, or you have people with this oscillating viremia, and I think that's quite important to remember, because subsequent data showed that even if you spontaneously cleared, so were negative by week 12, your chances are that you will revert back to being Hep C positive RNA after week 12, and indeed only 3% in this European data were negative after 48 weeks. So I think that's important. If you get someone who's got a very rapid viral load drop, fantastic, they may spontaneously clear. But it's important to check it regularly because they will often rebound, and I think that's what we see quite often in clinical practice. So how serious is it? I mean, that's the one question that people want to know. People want to know, you often get asked, how long have they got? And this was the Poinard data, which was the first data to really show the rapid progression to cirrhosis if you have HIV and Hep C, faster than all the other diseases or conditions that will cause progression to cirrhosis. And it's influenced by a number of factors. Some of them identified in the Poinard study and some of them identified later. So your CD4 cell count's important, your uncontrolled HIV viremia is important, age at infection, duration of infection, and if you've got high initial fibrosis and necroinflammatory score. If you're male, and alcohol consumption goes into it, and Poinard identified this greater than 50 grams per day, which is about 5 drinks a day, which is actually quite a lot. And there have been a number of studies which have looked at lesser degrees of alcohol intake, quite conflicting results, but I think people feel that even a light to moderate use of alcohol does impact on fibrosis, but obviously not to the extent that a higher alcohol consumption will. And now there's interest now in BMI, steatosis, insulin resistance, and the impact on progression to cirrhosis. So should he start ART? And I think what we know is that you can impact on progression or rates of progression. And if you look at people on no ART, so the HIV positive, they have faster rates of progression than those who are HIV negative. And by starting ART, you can influence it to some extent. You can slow the rate of progression by controlling HIV viremia, but you can't return it to the level of those who are HIV negative and Hep C mono-infected. But I think it's fairly clear that you would want to treat an uncontrolled HIV viremia to try and control hepatitis C disease progression. And there was some data at CROI that was presented looking at SVRs and looking at cytokines, and higher levels of IL-6 and IL-9 were associated with a lower SVR. So whether you get the kind of cytokine and chronic inflammatory state with uncontrolled HIV, and that's the reason why you get faster progression of disease. So these are the current EACTS guidelines, looking at recommendations for treating people who've got HIV and Hep C. And I guess it's fairly clear-cut. So if your CD4 count's under 500, if you're going to treat the Hep C or you're not, you have to control the HIV viremia. But I think in the levels greater than 500, I think some of us are erring towards treating early. So what the guidelines say is if you're considering Hep C treatment, CD4 counts over 500, then you can defer ART and treat the Hep C first. But I think this is the group that you'd probably be most concerned with. So Hep C treatment wasn't feasible, or they decided not to do it. So the recommendation is that use of ART should be considered, but I think it should be strongly considered, and I think most people practicing in this area would start ART in that situation. So then if we talk about eradicating Hep C, and I think it's quite interesting to look at the concepts of latency, and I'm sure you've seen this slide before, but I think it's quite useful just to go back and compare it to the other viral infections that we deal with. So we know with Hep B, covalently closed circular DNA, it's not integrated into the host DNA, but it does sit within the nucleus. It's got a very long half-life, and it acts as a viral template. And so it's there able to start reproducing new virions if it's given the opportunity in the absence of antiviral treatment. And HIV, we're all very aware, has got latency in resting memory T cells, and that's due to integration of the HIV genome, the proviral DNA, into the host cell DNA. And it can sit there for a very long time, and also obviously acting as a reservoir for wild type and also treatment resistance variants. And the wonderful thing about Hep C, it's got an entirely cytoplasmic life cycle, so you are able to eradicate it. It doesn't exist in a latent form, so we are able to cure it. So what are the goals? I mean, the primary goal, I guess, is to eradicate the virus. And there are additional goals. We know that it will slow disease progression, minimize the risk of liver cancer, improve existing liver damage, enhance quality of life. We've all seen the studies looking at fatigue in individuals with hepatitis C, prevent onward transmission of the virus, and I think this is very important, particularly with sexual transmission and MSM, and also reduce the extrahepatic manifestations. So what treatments are available? So in the UK, we don't have access to the new drugs. Even in Germany, with access to the new ones, it's still piggybacked onto interferon and ribavirin. And there are still indications where we would use and treat with interferon and ribavirin. So I'm sure you're aware this is what they look like. Pegylated interferon, once a week subcutaneous injection. It boosts immune activation. Ribavirin, which is an oral antiviral, which is given it's weight-based. And so these are the treatment outcomes, and again, I'm sure very familiar to most of you. So we could see from very early on in the big studies this big division between individuals with genotype 1 and genotype 4 and individuals with genotype 2 and 3. What you can see is that the SVR rates in genotype 2 and 3 were between 44 up to 73%. And in individuals with genotype 2 and 3, pegylated interferon and ribavirin is still standard of care. But obviously, if you look at the genotype 1 group, SVR rates in the studies between 14 to 38%, and it varied by study depending on the number of serotics they had, the number of people of African heritage. But this has really been the main driver for development of the new drugs, which are targeted at genotype 1 because of the very low rates of SVR seen in this group. So I'm not going to talk about the new drugs except for these 2 slides. But this is the Hep C life cycle and the activity of the DAAs, and every aspect of the Hep C life cycle has got potential activity. In particular, the NS3 and its cofactor NS4A, the protease, and the inhibitors telaprevir and boceprevir, this is where they act. And also the NS5B polymerase inhibitors, and these are the 2 areas which are currently being targeted for drug development. This is a slide from Sanjay, and it does seem to change on a day-to-day basis, but these are currently phase 1, phase 2, and phase 3, and as we know, telaprevir and boceprevir are now licensed for use. So it's really exciting. I think the thing about this as well is that everyone got very excited initially with when telaprevir and boceprevir were coming through, but now we know there's so much better things coming through behind, things that are more efficacious, things that are easier to take. So it's almost like you feel a bit spoiled. You know, we don't want telaprevir and boceprevir anymore. We want the new ones. So I think there's an issue as well that even when you do get access, and in the UK hopefully later this year we'll get access, do you actually want to use them? Or are we going to wait? And I think they're the big issues currently that we have to discuss with our patients. So this is current guidance. This hasn't changed, although it may be about to change later this year. So what you can see is it's very much based on virological response. So at week 4, if you have a rapid virological response and you're Hep C RNA negative, genotype 2-3, 24 weeks of therapy is recommended. Genotypes 1 and 4, 48 weeks is recommended. If, however, you don't achieve an RVR and you're Hep C RNA positive, the next time point is week 12, which is your EVR. If you've more than a 2-log drop, then you continue to week 24. If you're negative, genotype 1 and 4, plan to go out to 72 weeks. That's an enormous length of time. I don't know if anybody is able to. If you look at the studies, the drop-off rates, You start out with 100 and you end up with one who actually manages to make it to 72 weeks. But this is the current guidance. And I think the difficulty, and I think the thing that we all face is we're all very aware of the literature, but when you've got the patient in front of you in clinic, you're really looking at patients, not populations. It's really looking at this person in front of you and thinking, what's the best thing you can do for this individual? And it's kind of a balancing act, isn't it? So you've got the chance of cure, you've got the chance of getting rid of it, getting an SVR, you're going to improve the quality of life, you'll prevent transmission, which I think is really important, although you have to prevent them getting reinfected, which is an increasing issue. And you'll prevent cirrhosis and HCC. It's job done. You've got this chance to do this. But then on the other hand, you've got the chance of failure. And in genotype 1, you have a very high chance of failure and not achieving SVR. The adverse effects of treatment are not insignificant. And I think the more I've treated this over the years and seeing the impact on people of interferon treatment, relationships breaking up, people losing jobs, it's not insignificant. I mean, we do see this quite a lot. People start with a job, then they get laid off sick, and then all of a sudden they're made redundant. So I think that's something that I don't ever take terribly lightly when I'm counselling someone about the likelihood that they're going to need a year of treatment. Quality of life during treatment's not great. And we know we've got the new treatments. And even we're going to have new treatments. And we've got this tantalising prospect of an interferon-free regime, hopefully within the next 18 months to 2 years. And also, you may actually be treating someone who's got very low risk of disease progression until we can access good treatments. So I think they're all the issues you have to weigh up. And luckily now we've got a couple of things that we can actually use which can place people in the likely to respond camp or the let's just wait. So you're all aware of the adverse effects of antiviral therapy, and I could list several slides of side effects of pegylated interferon, but they're just the main ones. Also ribavirin, not without its issues. And also, are they ready for treatment? I mean, this is something we spend a great deal of time exploring with people. Even if you're going to treat someone, are they actually ready for treatment? Particularly in terms of the psychological side effects. And this is the thing that I find most concerning. And we've all had people who've started on treatment and become suicidal fairly quickly with very rapid, severe depression. So you have to explore that quite carefully. Do they need psychiatric review? Do they need prophylactic antidepressants? Do we start before we put them onto interferon? You have to look for autoimmune disease, including thyroid, other comorbidities. And also the social situation. Have they got people to support them? Have they got friends, partners aware? Have they got any big life events coming up? Are they going to change jobs? Are they going to move country? Is this the right time for them? Are they practicing safe sex? Are they IVDUs? Do they use cannabis, which we know impacts on psychological side effects during treatment? What's their alcohol intake and what's their current ART regime? So I think they're all the issues that you try and explore with somebody when you're thinking about treatment. This slide's a bit old now. I'm not sure we believe abacavir anymore. DDI contraindication, efavirenz, and there's also the newer ones coming through with darunavir. Should you use maraviroc in individuals in terms of its antifibrotic effect? And I think this is the big question. He's sort of saying to you, how likely am I to respond? He wants a number. If you give him 20%, he's going to say no. If you give him 80%, he's probably going to say yes. So he wants a number. So I think the way to approach this is to think about what factors negatively are associated with an SVR. So if we look at the virus first, it's very clear, very early on, that genotypes 1 and 4 are so negatively associated with SVR. High HCV viral load, we also know this is a very important predictor. I think quasi-species are going to become more important. I think this was first looked at in terms of spontaneous clearance. So if you've got quite a narrow viral repertoire, you're more likely to clear, whereas if you have a more extensive viral diversity, you're less likely to clear. And we can now see that this does also impact on response to treatment. I think this is going to become more important, and also the viral SNPs. If you look at HIV immune status, again, we know uncontrolled HIV viremia and a low CD4 count, or if you're immune suppressed for any reason, including post-transplantation, this impacts negatively on your SVR. So already you're beginning to pick out things that will be able to inform this individual whether you think that they will have a good chance of getting an SVR on interferon ribavirin. In terms of the patient, we know if they're older, longer duration of infection, and if they've got advanced liver fibrosis. We know if you're of Afro-Caribbean background, and that's primarily due to host genetics. If you're male, if you've got high alcohol intake, and now we're interested in the steatosis, high BMI, insulin resistance, LDL receptor status, which I'll show you a slide on later, and statins. If you're on statin, this was data presented at CROI, you seem to have a higher likelihood of obtaining SVR. And there's also the big thing in the last couple of years, your IL-28B status. So all these factors will allow you to put him into more likely to respond or less likely, let's wait. So this is the IL-28B, and this was very exciting. And what they did was they identified 7 polymorphisms in this 17 kilobase region around the IL-28 gene, of which the one that demonstrated the greatest effect was this one. Almost a 2-fold increase in your likelihood of SVR, taking into account other baseline factors, and associated not only with response to treatment, but also spontaneous hepatitis C clearance. So I think this is another important piece of information that you have in your clinic. I mean, I think it's interesting. I don't think you would ever completely base your treatment response on it or the likelihood or your advice, but I think it's interesting. And as you can see, this is your likelihood of having the favourable one, which is CC, or CT, less favourable, or TT. And what you can see is that if you're European or Asian, you're more likely than if you're African or Caribbean. And this was the ideal trial. And the interesting thing was that even if you're African American, which means that you're less likely to have the favourable genotype, it still predicts response. So you can see in the European Americans, if you've got the favourable genotype, your chances of SVR were greatly increased compared to if you had the TT or the TC. And although there was lower prevalence of the favourable genotype in African Americans, it also predicted response. So I think that's quite important. So if you do have the favourable genotype, then you are more likely to respond no matter what your genetic heritage is. And I think this was quite an interesting slide as well, which looked at the kinetics of Hep C decline, and it happens very early. So from very, very early, within the first week, if you're a favourable genotype, your Hep C RNA on treatment is declining more rapidly than the other genotypes. So it does seem to have an important impact. But I thought this was really interesting data as well. This was data from Croy presented this year from the Spanish group, on Pineda's group. And what this showed was it looked at your low-density lipoprotein receptor, and what it seemed to do was have a synergistic effect with your IL-28B status. So this is the data from the previous slide, which looks at your IL-28B of your CC or your non-CC and the rates of viral decline. But what you can see here is if you also have a favourable LDR receptor status, your rate of viral decline is very different from someone with a favourable IL-28B genotype but doesn't have this favourable LDR receptor status. So it seems that the two act synergistically, and even if you've got favourable IL-28B, if you don't have this favourable LDR receptor status, then you're pushed back into the same outcomes as. I think it's interesting. It's preliminary data, but I thought it was interesting. So I think the story is a lot wider than just your IL-28B status. So now we move on to the predictors, the Prometheus index. So this is based on a logistic regression model, and what it does is it looked at 4 factors in order to predict your likelihood of having an SVR to interferon and ribavirin from 0 to 100%. And its ROCR there under the curve was 0.86, which is really very good, really quite impressive, and it seems to be better in the HIV Hep C co-infected population than in the Hep C mono-infected population. So it takes these 4 predictors, your genotype, your fibrosis stage, your HCV RNA, and your IL-28B. It's freely available, that's the web thingy. And if you play around with it, it's quite interesting to see. So your liver stiffness doesn't really seem to impact hugely. Genotype does, but your HCV RNA level impacts hugely as well as your IL-28B. So it's just interesting to play around. And again, it's not an absolute, but you're just beginning to have a discussion with your patient about whether they should wait or whether they should go ahead. And I think this is quite important, though, for all our predictors and for all our markers. If somebody has an early virological response, that completely trumps anything else. So if somebody manages to get an RVR, no matter what their IL-28B status is, no matter what they started out in their HCV RNA, if they manage to do that, they immediately get put into the group where they were likely to have an SVR. So it's kind of tempting that you will be able to tell someone with a greater degree of accuracy after 4 weeks of treatment, although by that time they've obviously started on their treatment journey. But I think this is the really important thing. So actually really early on, you can say to someone, actually, you've got a really high chance of getting an SVR, or really, it's not going to work. And we do know the stopping rules by week 12, and that's really what they're based on, your likelihood of response. So what's the urgency for treatment? We've kind of had a rough idea of where he is and what his likelihood of response, but there's one thing that will determine whether you push someone into treatment who's got quite a low chance of SVR, and that thing is the degree of underlying liver fibrosis. What's the urgency? Do we have time to wait, basically? So these are your options. You've got liver biopsy, you've got the blood tests, or you've got elastography. And this looks a bit medieval, to be honest. Patients don't tend to like getting a liver biopsy. The risks are very low now. You do it under ultrasound guidance. It's probably the best we've got, although it's not a gold standard. But you'd obviously much prefer a nice Dr. Pagani with his FibroScan machine. He looks very benign, doesn't he? So his probe, no needles, 5 minutes and he'll give you a number. And this is the staging of fibrosis, which I'm sure is very familiar to all of you. So no fibrosis, obviously on your Metaview scale, a bit of portal expansion of fibrosis, that's F1. Moderate, you're starting to get a few bridges or septa. F3, you're moving into numerous bridges, and then cirrhosis. This is guidance which I think was really, really helpful. I mean, it's certainly the way that I've been thinking. It was just nice to have it clarified, to be honest, and put down. I thought it was brilliant. If you've got minimal fibrosis, in general, you can defer treatment. In general, you have time to wait, and people are getting very excited by the thought of interferon-free regimes. Patients are getting very excited, but really with F0, F1, and you really probably would wait. It's more difficult when you move into the more advanced levels of fibrosis, F2, F3, and particularly the F4. But the intermediate groups, the guidance is to treat with PEG, ribavirin, and a protease inhibitor if you can. We don't have access at the moment, although they're trying to put our patients in with a PI through expanded access or clinical trials. And obviously the group with F4, they're the group that desperately need treatment. They're less likely to respond. And I think for a lot of our patients, they've failed pegylated interferon ribavirin already. And you're waiting desperately for access to the new drugs, although these are the naives. And then also this was from the same, again, I thought it was incredibly useful. So what this does is it separates into your previous response, naive, relapse, and non-responder, and your grades of fibrosis. So I just thought I'd touch very, very briefly on IVDU, and is it a contraindication to treatment? So this was the European consensus. They had a conference basically saying active drug use is not a contraindication. Full benefits are not compromised when they're successfully retained in treatment. Should be offered opiate substitution therapy, and if they're not ready to stop drug use, then initiation should be on a case-by-case basis. It's a situation in Central and Eastern Europe that it is really exclusion, and this is the area where IVDUs are the ones that are predominantly affected with co-infections in terms of access to treatment. Retention and treatment and cooperation is quite difficult, and I just put this up just really as a discussion point. So in conclusion, co-infection's common. There's increasing incidence of acute Hep C and MSM. We are going to see end-stage liver disease, significant cause of morbidity and mortality. We know that in co-infection, early ART is beneficial. You modify the other risk factors, particularly alcohol, and I do say to people to, if possible, cut it out, high days and holidays. You need to assess the fibrosis stage because that will be the primary thing that will assess the need for treatment. Drug use isn't a contraindication, but you need specialist service involvement. And the predictive algorithms, useful, but as I said, an early virological response trumps everything. And the treatment is about to get enormously better. I mean, I think that's the exciting thing about Hep C, that within the next year or so, we are going to have access to some really, really good drugs. So thanks to Sanjay for some of these slides. Thank you.